so much for inviting me to be here today and to be a part of this great panel. It's really an honor. And I love getting to, can you hear me okay? I love getting to represent physical therapy and especially pain neuroscience education. I spent 6 months last year getting a certification as a therapeutic pain specialist, and pain neuroscience education, I think, is on the forefront of helping us help our patients do better with these chronic pain states. The APTA says that we are transforming society by optimizing movement to improve the human experience. So first and foremost, physical therapists are movement specialists. Everything we do should be in the service of movement and function. I wanted just to briefly cover some of the things that we do that are similar to some of my other folks on the panel. We do some modalities to help manage pain. There's inconsistent evidence out there. Laser is a real hot thing right now, and I'm seeing some patients benefit tremendously from that. And we use our hands. Our chiropractors use their hands. Acupuncturists and massage therapists use their hands for a variety of things. Physical therapists do anything from, a few of us do high thrust manipulation, not as often, lots of massage and down regulation kinds of things, but also mobilizations to try to correct biomechanical errors, decrease pain, and again, help people to move better. What I think sets us apart is that we're exercise and movement specialists. Our license actually tells us that we shouldn't be doing anything just to decrease pain unless we're also increasing function and movement. So we spend time educating and coaching. But what do we do with those patients? And I've met them, you've met them. I have friends tell me, I can't get my friend to see you because she went to therapy somewhere else and it hurt. So what do we do when exercise hurts too much? Our challenge, and I think this is for all of us, is that our orthopedic model has focused on tissue and tissue injury. Fix the biomechanics at fault and the person should feel better. Unfortunately, that works fabulously for our acute and subacute patients, and we may be starting to create more fear and anxiety in patients when those techniques aren't working, and that fear and anxiety can contribute then to chronic pain. So we have to really understand the definition of pain if we're going to help teach our patients how to get out of it. And that definition includes the emotional experience. It includes potential tissue damage, not just actual tissue damage. Lorimer Mosley is one of the founders of pain neuroscience education. There's tons of research. I have handouts over there for you. And he says it's a multiple system output activated by the brain based on perceived threat. So we know that one's pain experience is not determined by tissue damage, but it's our job to teach our patients that. So I believe how we can improve is with pain neuroscience education, which isn't just us knowing what's going on in the brain and nervous system, but our patients want to learn this. They can learn this. And when they learn the neurobiology and physiology of pain in their brain and their nervous system, it decreases the threat value. It's a powerful tool. We can set realistic goals and help coach them. There's those people who just keep doing too much and booming and busting, and there's those people who are sitting on the couch. We have to have different strategies for both of them. I use a lot of down regulation practices. It's something I've been practicing for decades, and I teach my patients how to sleep. We have functional MRIs that show that pain neuroscience education works. So slide A is a brain on pain. You've probably seen things like this before in different pain presentations. I'm going to jump to slide C. 2 to 4 hours of pain neuroscience education, and that person's brain activity as well as their pain experience significantly decline. So it's a powerful tool. We need to be aware of what we're saying to our patients. Over this past year, I've been introduced to the nocebo effect. I don't have time to go into it today, but when we're using words that we always use, that our patients don't understand, again, we're contributing to fear and the positive negative effects that that fear can cause. We tell them they got bulging disc, full of arthritis, tears here, strains there. They don't know what that means other than that we're giving them a life sentence, right? Our current research shows that 30 to 50% of the people with these kinds of imaging studies don't have symptoms. We shouldn't be giving them those reports unless we're also telling them that's only a part of what's going on with them. There's other things that we can help them with. This isn't part of pain neuroscience education, but I ask all of my patients, do you have a trauma history? If I'm going to educate them about their brain and their pain, I'm just going to let them know that that history has very likely made their brain more susceptible, more sensitive, more reactive to their pain experience. And I'm trying to help teach them that they need to start learning how to control that autonomic nervous system, that dysregulation that they have. Hopefully Scott's going to talk more about that. I teach patients that when they have pain, every system is involved. They feel like they're going crazy, but that pain experience, that constant sympathetic release, is causing their immune system, their endocrine system, their motor system, their sleep, everything's going offline. They're not going crazy. They just have a system that's being overstimulated constantly. I teach them not to trust their alarm system. Their painful alarm system goes off often, with a strong wind, I tell them, right? So I give them the mantra, my hurts don't harm me. Again, that doesn't mean I want them just pushing and doing everything. We need to learn how to pace and not trigger that while increasing their movement tolerance. Teach them about ion and ion channels and sensitivity. I show them images that your nervous system is all connected. So if your pain started somewhere, but now you're having strange symptoms somewhere else, we need to biomechanically evaluate it, and it's likely that that connection in the brain and the nervous system may be causing symptoms that aren't easily explained. So we need to calm the sensitive nervous system. Movement and exercise is paramount, and I believe physical therapists are excellent at that if they understand chronic pain. Pain neuroscience education is paramount, and we can all do better at that. We need to set realistic goals and get them moving again, but not just think they can go to the gym and do what the rest of us can do easily and naturally. Sleep is important. Manual therapy can be extremely effective when used in the service of helping people move again. It's the same thing I say for injections. Get your injections and feel better, but don't not do anything. Use that decreased pain to start moving more. Patients need to feel safe. Often the medical system, if you haven't figured it out yet, is complicated and scary. And we're not always the most safest people for our patients to be seeing. We need to create an environment of safety. I use a lot of relaxation, mindfulness, and good pain counseling. And I was talking to Scott earlier. It's different getting counseling for pain than just the depression and anxiety that might be going along with it. So my hope is that we'll get better skilled pain counselors available to our patients. I teach my patients that pain is normal. We sort of have a whole culture of people that think any amount of pain isn't acceptable and maybe they shouldn't do anything at all. So again, they're afraid. We've got to teach them it's okay to move through certain kinds of pain. Your pain is coming from your brain, even if it is biomechanically generated. Your brain is determining how much pain it's going to give you on that scale of 1 to 10. We want to educate them on how important it is to move. They can't just be sitting or lying around. I teach them about predictable stages of healing. If they had an injury and we're past that 3 to 6 months of acute and subacute healing, chances are pretty good their brain and their nervous system are getting involved and overly excited. And I give a 50-50 approach. As you know, a lot of our patients are extremely wedded to their imaging results, right? They've got torn this and full of arthritis that, right? But even if 50% is biomechanical, 50% probably is that pain and nervous system that we can calm down through these kinds of strategies. So thank you. I appreciate my 8 to 9 minutes.